our special webinar today focused on the impact of social determinants on readmissions. And this has kind of been an emerging issue with our hand and a topic around the country, not specifically with readmissions, but across the board. But we wanted today to focus on those readmissions. Today we are pleased to have Dr. Andrew Masica from Baylor Scott & White Health presenting this information to us. We hope that you find it useful and beneficial. He'll run through some of the background of these social determinants and then review a program or a pilot program that has been going on at Baylor Scott & White for a little while. We'll have time for Q&A, and then we just wanted to review some late-breaking data that is the result of our most recent data collection for our HEN that is showing some good and impressive results. So I think with that, we'll go ahead and turn the time over to Dr. Masica to get us going.
Great. Well, thanks, Jason. And for those who haven't had a chance to check their computers or didn't take a long lunch, the U.S. soccer team, they lost, but they had scored enough goals so that they still moved through to the next round. So well, we can continue to watch the World Cup with I suppose, a more vested interest. So the other thing is that we probably have about 25 minutes of content. 20-25 minutes. We will leave some time for any discussion or questions at the end of this. Throughout the slides, if there's anything that you need clarified or would like to ask as a specific slide is presented, just use the chat boxes, and then Jason will have me pause. Okay, so thank you for your time. We will try and be efficient here. So Jason, please move on to the first slide. Second slide, I should say.
Okay. Are you seeing the readmission within 30 days of discharge?
I'm seeing the screen that says, I'm seeing the title screen.
Okay. Let's see what's going on here. Okay. Sorry, we're having some technical difficulties, but let me try something else. Is this any better?
I'm still seeing the title screen. Oh, there we go. Now I got it. Okay.
Oh, okay. We're good. Okay. Sorry about that.
I'm seeing nothing.
Nothing. Are you sharing your?
Okay.
We good?
I see it now. Okay. If you want to blow that up, just resume slideshow.
Yeah, it's just a little on delay, I think.
It looks like we've just got a really long lag in our Okay, well, I don't want to mess it up any more than I already have.
Okay, well, I think at this resolution, okay, there we go. All right, so just a quick recap on why this is an important topic. For any number of reasons, people are concerned about 30-day readmissions. There's bad for patients, costly to hospitals. There are also now associated penalties from CMS. When you look at what impacts readmissions and what moves the needle on improvement efforts, when you do a close look at them, many of them, when you formally test them with a rigorous design, the impacts have been somewhat disappointing. And I think one of the things that you'll see as a common theme throughout the literature is that one size does not fit all for these readmission strategies, and other authors have encouraged that when you're looking at these programs, you need to take the time and effort to do a thorough evaluation of what is working and what isn't working. Speaking to some of our own experience at Baylor Scott & White Health, we're fortunate to have a good amount of resources to do those internal evaluation efforts, but just I can give you one specific example. We were looking at the impact of follow-up phone calls on our patients. And what we found was that there were calls going out from sort of the corporate and the system level. There were calls going out from the individual hospitals. So that when we paneled a cross-section of patients, some folks were getting 5 and 6 different phone calls, which one was a bit overwhelming for the patient, and two, it just wasn't very efficient. So one of the things that we actively have going on now is trying to narrow down those number of calls and figure out which calls and from whom are the most effective. So that's just a specific example within the Baylor healthcare system. I'm sure you have other examples within your own facilities and organizations. Next slide, please.
We're still having slide issues. Okay.
It's just lagging.
Okay, well, it looks like it's going. Unfortunately, I think there's only 18 slides total. So,
yeah.
All right. The other article I would point out is this is a recent review that was in JAMA, Internal Medicine, and it's a meta-analysis of clinical trials that looked at prevention of 30-day readmissions. And while Jason's working on the resolution, the common theme was that the interventions, and you'll see this throughout a number of articles, interventions that were multifaceted and were more intensive, those are the ones that tended to be more successful. Again, that's probably something that mirrors our own experience within our organizations. Just focusing on one piece, say medication reconciliation, that by itself isn't going to reduce 30-day readmissions. It has to be medication reconciliation done with care planning, connection to a medical home, potentially some home follow-up visits with high-risk patients. Again, it takes those multiple levers to actually drive down the 30-day readmission rates. I think the good news is, as based on this meta-analysis, that these interventions can be effective, but I think it's important to have realistic expectations in terms of what sort of isolated and singular interventions can do, and really what sorts of resources internally you need to make to actually reduce these things. It takes time, it takes effort, it takes personnel, and I think that's an important message that needs to go to the C-suite. This isn't something that just happens. So again, it's a good article, a lot of information in there. I would strongly encourage using that as a reference for your internal efforts. Next slide, please.
I think it's coming.
Okay. We don't want to lose our audience here, Jason.
I know. I'm wondering what the holdup is, but maybe I'm going to just have to keep messing with it.
Is there any way, could we, I know we don't have everyone's email. Do we actually, is there a way to email them and then we can keep the audio link live and then people can just follow the slides that way?
Let me actually see if I can share the file with the group.
That's probably the easiest way to do that, and then we can move through this efficiently.
Yeah. Sorry about this, everybody. I will post the file onto the slides, and then we can just all follow along at the same time. Here we go. Okay, everybody. So there should be a tab now at the top of your screen that says the impact of social determinants.
Okay, Jason, I can see it, Jason.
Okay, so if you click on that tab, you can advance the slides yourself, So we are on slide number 4, if everybody's able to get there.
Right, so for those who, so on the screen, so if you click on the tab and then the arrows right under the tab will move it backwards and forwards. So we are on slide number 4 now, titled Transitional Care Interventions to Prevent Heart Failure Readmissions.
Yes. This is the audience
participant. 1 minute to get there? Okay. So Jason, can you, all right. So this is, everyone has individual control of their slides now, correct?
Yes.
Or are you still controlling them?
No, everybody should have individual control.
Okay. All right. So we're on slide number 4, transitional care interventions to prevent heart failure readmissions. So we had just referenced the meta-analysis done in JAMA Internal Medicine. This was an AHRQ similar meta-analysis. This one's focused specifically on heart failure. Jason will post this to the HEN website after he'll post the link, but again, it's publicly available and free. This study looked at 47 different studies to reduce heart failure readmissions, and the way to interpret this chart, the plus sign means that the specific type of intervention had a reduction in readmissions. The minus sign means that, and again, this is at meta-analysis level, it did not have an effect. So intensive home visits worked in reducing readmission, heart failure specific readmission rates, all-cause readmissions, and also reduced mortality. Some of you may have heard this. That's generally called the Mary Naylor model, where you have a nurse practitioner or some other clinical care provider will typically meet the patient in the hospital, then follow them through the home with in-person visits in the home for a period of time. So that model has been pretty well proven in multiple different studies. The flip side is that it's very expensive and resource intensive. Multidisciplinary heart failure clinic, that did not impact heart failure specific readmissions, but it did reduce all-cause readmissions and mortality. Structured phone support, that is basically, if the term is familiar, a health coach sort of talking through the patients. So for CHF, something might be following your weight, use of your medications, those types of things. It reduced heart failure readmission rates, but not all-cause readmission rates. It did have an effect on mortality. Across the board, telemonitoring and nurse-led interventions were not particularly effective in reducing any of the 3 metrics that this article looked at. So as we've said before, the common theme is that the interventions that tend to work, they tend to be multifaceted, interdisciplinary, and they tend to be very resource intensive. So again, a common theme that we see identified in literature. All right. So we have, within that broad context, it's increasingly being recognized that in addition to the type of care that is delivered, the population that you're working with and social factors really drive readmission rates. And again, if you this probably matches the experience you've had in your own organizations. So sort of taking a closer look at those social factors could potentially help target which interventions would be used, which becomes particularly important in an era of tight budgets and where the mantra is do more with less. So to that point, these are 2 figures from an article. It was actually a perspective piece in the New England Journal of Medicine, published about a year ago. And what this looks at, if you look at the top graphic, what that shows is the proportion of hospital beneficiaries who had supplemental security income. And what you see is, so that's on the x-axis. The y-axis is the percentage of hospitals that did not face readmission penalty. So what you see here with this graphic is that as your percentage of patients in that hospital on SSI increases, you have increasingly more of those hospitals are getting hit with a readmissions penalty. Sort of the same basic data in a different flavor is on the graphic in the panel below, the bar graphic. And again, what you see is that as the proportion of hospital beneficiaries on SSI increases, so does the amount, basically, there's a direct correlation between SSI and the percentage of hospitals that receive the readmissions penalty. And what that speaks to is that there isn't really a good, in the current formula, there is not a good risk adjustment for these socioeconomic factors. And this has been from American Hospital Association, other organizations. This has been a real critique of this particular metric. I think the organization, the sites that really tend to get penalized in this are teaching hospitals and safety net hospitals. So it's in what is somewhat ironic, the hospitals that can least afford these penalties are the ones that are getting hit with them. So, all right. Next slide. So now we're on slide number 7. This is just sort of a conceptual model of the different factors that influence readmission. So you have the level 1 social factors: age, gender, race. Those are sort of what you have at baseline. Not much you can do to change those. It's really more things you just need to recognize. The level 2 factors: education, income, insurance status. And then you move into the level 3. So these are things like social support at home, what their housing situations are, diet, access to food, the concept of a food desert. If you have congestive heart failure, trying to find fresh fruits and vegetables if you live in certain parts of certain cities becomes very difficult. So that is clearly a factor in readmission. And then things like health literacy, and then just sort of the resources within the neighborhood and infrastructure and support there also play into the readmissions. So you overlay that on clinical factors like disease severity, and then access to care, and that it almost creates a vicious cycle in terms of creating people at high risk for readmissions. And just within our own system, and I know some other people have looked at this, the factors that actually tend to outweigh the disease severity in many cases are these social factors: substance abuse, housing stability, support network at home. What we've seen, just sort of in our early experience with this, is that those tend to outweigh any types of clinical factors, which was somewhat surprising to us. So it's whether or not you have a good social support network at home is actually a stronger predictor of readmission than your ejection fraction. So that's both are hard to fix. I think sort of reinforcing the social support network is particularly hard to fix. So again, this is just a nice conceptual model of how this plays out. Okay, next slide. So thinking about the cause and effect here, readmission, when you look at readmission rate as a quality metric, and I know it's a controversial quality metric, and basis financial penalties, that, fundamentally are readmissions a result of poor quality, or is it really sort of, is it social factors and characteristics of the population? I think the answer is a little bit of both. There are levers that can be flipped to reduce readmissions, but you have to take it in the context of the population that you're working with. Things that are hard to, that can potentially be addressed at individual levels: health literacy, communication, in terms of languages, social support structures. That's at the individual level, and then also at the community level: provider availability, housing support, all those types of things. This looks good on a slide. I would say that obviously from a hospital level with stretched resources, most hospitals aren't in the position to try and address these things. So thinking about sort of the broader, it becomes more of a community type partnership when you're trying to work on this. And I know that historically that's just been very difficult. It's going to continue to be difficult just in the era that we live in, but in terms of both federal and then private funding availability. So the key question is, and I think just based on the data that we've seen here, and again, probably what you've experienced with your own systems, is should we reformulate risk adjustment models and penalties? I think the general consensus from the scientific community is that they had to start somewhere with the quality metrics. There's a recognition that they're imperfect. What we'd like to see moving forward is that there are much better and more robust risk adjustments to these metrics that don't necessarily penalize facilities that may be dealing with a more difficult patient population or a higher risk patient population. So I'll stop there. Okay, and this is just a reference list for the basis for these articles. And Jason will, I'm sure we can probably arrange to get these articles posted on the website to make it easy for people to find.
Yeah, we will, and we'll actually post these PowerPoint slides on the website too, under the resources for readmissions.
Okay, so I think again, I didn't want to spend too much time outlining the scope of the problem. We all know what's there and what our challenges are. What I wanted to do is just sort of give a brief summary of a pilot study that we did within one facility at Baylor Scott and White Health that was one approach that we've taken to help address this issue with socioeconomic status and readmissions. Okay, so I'm now on slide 11. The context for this particular pilot, there's pretty good evidence to support the clinical benefits of medical homes at this point. However, there's less clarity surrounding the financial impacts of these programs, particularly in underserved populations. For our uninsured population, our system actually subsidizes a network of community clinics. However, with the pressures that all of our systems are facing, Baylor's no exception, just in terms of scarce resources, we were asked to take a close look at these community clinics and see what the business case for it. There's obviously a social case that if you want to take good care of your patients, they need a medical home that they can go to. But we did want to take sort of a dedicated look on utilization and then the financial aspects of this program as well. We have a local foundation was very generous to us, the Irving Healthcare Foundation in Irving, Texas, and they gave us a $50,000 grant award back in 2012 to investigate this question using a good methodology. We had we had retrospective data, but again, we wanted to look at this prospectively and, if possible, actually design a randomized study. Okay, so this is slide 12. This is just a general, this is a schematic of how we designed our study. So if you look at the top left-hand corner of this slide, the hospital referral source for these patients was they either had an inpatient hospital stay, an observational stay, or an emergency room encounter. They were referred to the clinic staff, and then the outpatient clinic staff enrolled eligible patients. So typically what made people eligible was at least one chronic disease, hypertension, diabetes, congestive heart failure, COPD, or asthma. If you had one of those, you then became, you were uninsured, you then became eligible to receive follow-up care in this medical home clinic. And we collected baseline data, demographics, comorbidities, home status, and then other social variables. So there were two groups that we wanted to look at. So just the natural history of these clinics, if you enrolled them, you would have a percentage of patients that we refer to as the unconnected group, so that they were referred to the clinic, but they never reestablished follow-up. That is about a third to a quarter of our patients that get referred never actually showed up for their follow-up. The other group, and that's the middle box here, the connected group, so they got their referral, and then they actually established their follow-up in the clinic. That's the group that we're able to track much more closely, obviously. We can track the unconnected group from administrative data, but in terms of having clinical variables and really getting a sense of what's going on, it's that connected group that establishes follow-up in the clinic that we can follow, that we take a look at closely. So the other thing, I mentioned that we wanted to do this in a randomized way to have some solid data that we could assess this program on. We initially wanted to try to randomize people at the level of the clinic referral, but it was deemed that that would be unethical because there would be a certain set of patients that you knew really needed the clinic follow-up, and you just couldn't randomize them to saying, go have a nice life. What you really need to do is you want to ensure that that high-risk group actually has access to care. So we decided then that the next best thing to do was once they got in the medical home to test another type of intervention, and that was the impact of a care navigator. So we had a portion of an FTE was covered by the grant and to serve a care navigator function. And once this group was referred and connected to the clinic, we did a 1-to-3 randomization scheme. So a third of the patients went into usual care at the clinic and then care navigation, and a third of the patient, or 2/3 of the patients went in the usual care group. And then we looked at, we did outcomes tracking. And most of the outcomes tracking we looked at all had to do with utilization, 30 days, 90 days, 180 days, and then a year. Okay, so slide 13 just describes how the Care Navigator intervention was different from usual care. So usual care, patients did have a social worker, but with the Care Navigator, it was assigned sort of a caseworker type intervention. And if you look in the right-hand column, the types of support that the Care Navigator was providing, it was very much social support. Assistance accessing medication, assistance with transportation, appointment reminders, health literacy. Well, we'd love to sort of provide that very intensive social support to all of our patients. From a resource and timing standpoint, it just wasn't possible. So that's why we had to sort of split this role out. Again, this is not sort of explicitly the type of interaction that would take place between a patient and a physician, or even a patient and a nurse provider. It's really social support, more of a peer-to-peer interaction, somewhat similar to if you are familiar with the community healthcare worker model, more of that type of interaction. And again, something important to point out, just because we had a portion of an FTE and patients were continually enrolling on the study, the Care Navigator intervention lasted for 90 days. This is just some enrollment tracking data. So we had 418 eligible patients referred to the clinic over a 1-year period. 341 patients established clinic follow-up, and then 77 patients of those referred fell into the unconnected group. And then I talked about the randomization scheme. If you look down to the patients that we've accrued at follow-up, thus far we have all 341 patients have made it through at least 90 days of follow-up. 332 patients have hit 180 days, and 208 of them are at 365 days. And then you can see the similar numbers in the unconnected group. And I will say, we actually have just started to get some data back in the last couple of weeks, so I have more information on the connected group than I do on the unconnected group, but we'll see that shortly. Okay, so slide 15 is just our baseline demographics table, and one of the beauties of randomization was that you often run into the studies that have been published. There's often either the prospective and observational components of that. You get in troubles with potential confounders, and so a key advantage of randomization was that we're able to ensure equal distribution of things that we think might be predictors of readmission between the groups. So, and I didn't show every comorbidity, but comorbidities, the percentage of patients with certain comorbidities was similar between the groups, as were social and other demographic factors. Interestingly, I thought this was sort of an eye-opener to me. When you look at the population that was referred to this clinic, if you look at the first row in this table, so the mean age, 45 years. I was surprised at how young that group was. But then when I reached out, when we talked to the clinic site, that's typically the population they see. These are generally people that they may not be U.S. citizens, they may not be documented U.S. citizens, they may be people who have jobs, but those particular jobs don't offer insurance. So these are folks that sort of fall in between. They don't qualify for Medicaid or state support, yet they don't have access to commercial insurance. Even with the new healthcare exchanges with the Affordable Care Act, this is the type of group that's probably not going to be able to afford those types of plans. So I thought that was interesting. The other thing just to point out is just the urban community. There is a large Hispanic population. So you can see that there was 51% of the patients in the Care Navigator group, and then 43% of the patients in the usual care group were of Hispanic ethnicity. But again, as an investigator, you like to see no p-values were less than 0.5. So for all the things that we think mattered, the two groups were similar. Okay, so looking at some of our preliminary results, and this is really, as I said, these are the first cut of data. This isn't ready for the New England Journal just yet, but we saw a very interesting pattern. And I think the thing to remember when you look at these data are that the Care Navigator intervention was 90 days in duration. So, and what you have in the Care Navigator and the usual care columns That is the rate of, or the number of patients, individual patients who had a hospital readmission or a hospital admission event within 30, 60, 90 days of the index encounter. So what you can see is at 30 days, there's not a statistically significant difference in the group in terms of readmissions. 60 days, it starts to approach statistical significance, and at 90 days, that's where you start to see sort of the groups where it does become impressive in terms of utilization patterns. So in the care navigation group, only 4.7%, 4 out of 86 patients, had a hospital admission event 90 days after their index encounter. In the usual care group, again, so these are patients that had clinic follow-up, but were just assigned to sort of the standard medical home. They had an admission rate of 12.2%. So again, 31 out of 255 of those patients. That was statistically significant. One of the numbers that I think is very meaningful when you're talking about trial results is the number needed to treat. So if you that 7.5% absolute difference in admission rates, you would only need to do 13 care navigator interventions to prevent one hospital admission. So you think of all the things we do, these care navigators tend to be relatively inexpensive resources. An FTE would generally cost $40,000 to $50,000 a year. That's a pretty powerful intervention. One or two hospital admissions will generally cost more than $40,000 a year. So that I thought was very interesting. I think adding some credence to the impact of the care navigator intervention was once it stopped at 180 and 365 days, we actually started to see those patterns reconverge in terms of once the care navigator intervention washed out, there were similar readmission rates between the two groups. So to me, we interpret this as that for the period that the care navigator intervention was active, it did have a reduction in hospital utilization. And that is our business case in terms of why we'd want to have this person moving forward. Okay. So looking at this analysis from another perspective, I think the other aspect of this leading to the likely benefit of the care navigator intervention, you really see an incremental benefit of this type of support. So if you looked at the three groups, you have patients that didn't connect to the medical home at all, those who were connected, and those who were connected and had the care navigator intervention. If you look at the hospital admission rates at 90 days and 365 days per 100 patients, you see this trend. So those patients that were unconnected, they had a hospital admission rate of 28.9. The patients who were connected, it was overall, looks like there was a benefit to that, 13.5. And if you were connected and had the care navigator intervention, your rate was down at 4.7. So again, I think that's a pretty powerful, that is good evidence that this intervention probably works. Now, the other thing we wanted to look at was what happens when the care navigator intervention washes out. And again, I'll remind you that it only lasted 90 days, so by 365 days, you would expect that the effects to have waned. So if you look at that population that didn't connect at all to the medical home, they get readmitted at a rate of 76 out of 100. So I think here, if you look at the connected group, you can see the difference between just having a medical home available for these places to go. It appears that there's a benefit to reducing hospital utilization in that group. Without the care navigator intervention, even if you had it in the past, once that 365-day time window when it washes out, it looks like you sort of go back to the baseline rate of readmissions for the connected patients. So again, we're actually very encouraged. We think this speaks to the benefits of both, of A, having a medical home for these patients, and B, that you can really amplify the impact if you have a care navigator intervention in this group. Okay, so just a couple more slides here. Our discussion points, for those patients who establish follow-up in our community care clinic, it appears that the care navigation intervention reduced hospital utilization at 90 days compared to usual care, and again, this matched the duration of intervention. when the effects of that Care Navigator intervention waned at 180 and 365 days, the hospital utilization converged. I think germane to this discussion was that this intervention was successful in a high-risk, unfunded, and traditionally underserved population. So, and when you talk with different systems around the country, there's plenty of other examples of this sort of work going on. So, within our own organization, what are we planning to do with this? We're going to collect the remaining follow-up data through our accrual period of December 2014. We have a unique resource here in the Dallas area, the Dallas-Fort Worth Hospital Council database, and we can get readmissions data on 70 hospitals across the Dallas-Fort Worth Metroplex. One of the things that we did not want to see happen was that we don't want to be just shifting our admissions to other hospitals within the city. So we want to know if we truly are reducing the global hospital utilization rate, or are they just not? Are they showing up in other hospitals in Dallas County? So that's something we want to look at. As I said, these data were hot off the press, so we still need to do some statistical adjustments, particularly on the observational portion of the study. Cost effectiveness analyses. The way we're going to do that is to demonstrate the business case for these programs. Is we're going to look at the total number of hospital admissions that you could potentially prevent in this population over the course of a year, and we're going to assign an average cost to each of those admissions for patients in this type of population, and that's how we're going to cost out the intervention. We're going to cost out the potential benefit from the intervention minus the cost of a Care Navigator program. So we think we'll come out in the positive on that, but it will be very helpful for our leadership and our finance folks to be able to see that. So again, there's clearly a social benefit for having these medical home programs, but you also got to demonstrate the business case. Ultimately, just because we were able to do this in a randomized fashion and we had a pretty good sample size, we're going to try and present this at some national meetings and get a paper published. More important than that is that this has actually triggered a very nice internal discussion about do we roll out use of Care Navigators across the system more consistently. So, and again, I think something to point out is that we call them Care Navigators here. Similar model would be community health care workers. Some places call them health coaches. The point is that having that hands-on, more intensive interface with social support, that seems to be consistently an intervention that will help reduce readmission rates. Okay, so that is all I have for my formal presentation. We will open up for questions, comments, and discussion.
Great. Thanks, Dr. Masica. Amanda, if you could unmute all the lines. It doesn't look like we've gotten any comments in the chat box, but we'll pause here and see if there are any questions or comments on the phone line. I believe they're all unmuted now, so just go ahead and speak up if you have any comments or questions.
So I see one comment from Teresa Wallace. Could we have him talk a little bit more about what specifically a Care Navigator is or does? I think I know, but want to make sure.
Well, I'd say there's multiple definitions. We looked at it as, the term Care Navigator comes up in literature. We looked at it as sort of a social worker plus that, again, would sort of go that extra mile for a very hands-on type of intervention. So an example would be they would make sure that patients had transportation to their clinic appointment. Or rather than just, if there was issues, they would follow up with them. And it also, what they did was they had an interactive channel of communication so that the patient was also free to contact the Care Navigator at any point in time for extra assistance. I think that's important, rather than just going to sort of the general, the clinic phone bank and then trying to address things that way. So I would say that it tends to be a hands-on, focused on sort of practical social support issues. That's how we use the Care Navigator in this setting.
And Andrew, who employed them?
So we actually, this was it was a social worker who was her main employment is through through the clinic. Our organization basically funds, with operational dollars, funds a network of community care clinics. So her time to do the care navigation, that was actually, we bought out about a third of her time, and that was paid for by a grant.
Okay, thanks.
All right, so it looks like maybe the questions are going to Amanda. So Amanda, are there any other chat or text questions? Looks like not. Okay, so are there any other questions or points of clarification from those on the phone?
Oh, sorry, I have one more from somebody. Just wanting to know where the slides will be available later, where they'll be available.
They'll be on the henlearner.org website, and we're planning on sending a newsletter out later today or tomorrow, and when I send that newsletter out, I'll have a link specifically to where those slides are posted. We just have to go through them and get them ready to be posted on the website. So it'll be either later today or tomorrow, but I'll send it out to the mass email list when I send the newsletter out.
And I don't see any other questions right now in my queue.
Okay, great. Thanks, Amanda. So any other comments or questions from the phone line?
Teresa again. Jason, can I just ask one more question? I don't see the slide, so I can't remember exactly what I was thinking about, but on the one slide where you talked about the number of folks that did not do their follow-up, I wonder, did you do any kind of deep dive to see why those did not do the clinic follow-up? Were they actually, you know, did the care coordinator attempt to get them there and they just couldn't get them there? Did she make one attempt? Did she make 5? I just wonder if there's any.
Right. Typically, we have there are up to three outreaches.
Okay.
Where the care coordinator would try and get them. Now, interestingly, this is a population that they do not. It's unbelievable how difficult it is to get them to answer their phone. If they see the hospital calling, they think they're calling with bills. To be quite honest, so it's a very hard population to reach via phone. We looked at, and I didn't show just for time purposes. There were some differences in the unconnected group and some of their baseline things. So they tended to be, more of the unconnected group tended to be single, more of them tended to be male. Those are 2 risk factors for noncompliance. So that's, part of it is, again, and we're trying to adjust for those in our subsequent analyses, but that's why we were so pleased to be able to look at the impact of the Care Navigator in a randomized fashion, because then you just have that more robust data set.
Thank you.
So yeah, our hypothesis is that there are probably some confounders that are contributing to the patients being unconnected.
Dr. Masica,
Right.
this is calling from Dartmouth. I'm just curious what kind of caseload and how you operationalize the Care Navigator. What was the training like for them, and then what kind of caseload did they carry?
Sure. So they worked. We have at a system level, we have a health coach program. So they worked through that, and then our community care clinic program has been well established for almost nearly a decade now. So there's good familiarity with what works in this type of population. Again, the key was buying out a portion of their time to be able to do this. At any given point, she probably had, with her normal activities, she probably had 60 to 70 patients at any point in time that she was actively managing, and then they would roll off after that 90-day period.
Okay.
Now, if you had the thought would be, if you had a full-time person doing this, and what the community health care worker literature tells you, that caseload is upwards. You know, it depends. 150 to 200 patients is what you'll typically see.
Okay.
If you think 1 or 2 visits a day, that's generally what people can do.
Okay. Thanks.
Sure.
Great, thanks. Are there any other questions? I have one. So, Dr. Masica, so you are kind of in the process of making the business case for this program, and based on the data you showed, and correct me if I'm wrong, but after the 90-day care manager period was over, things started to all kind of coalesce, and the readmission rates kind of all showed the same. Is there? I'm assuming that the case you're making is to continue the 90-day care manager period,
right,
but
so
is there?
Yeah. Oh, go ahead.
Oh, well, I was just going to ask, is there any reason or something that you guys are looking at to see if maybe the care managers should focus the attention more on like an education thing? It looks like whatever the care managers are doing aren't necessarily sustainable once that connection's lost.
Right, because again, it's the things that, it gets back to that mechanism of social support. People that had difficulty getting a ride to the clinic before the Care Navigator intervention, once they weren't actively getting help, in most cases their social situation isn't going to change substantially. And so that, I think that's sort of the rub with this intervention, is that it does have to be hands-on and continuous. Now, most of the health coaching and again, care manager, community health workers, one of the things they try and do is encourage self-management and empowering the patients. That takes time. So maybe you might not see, maybe a better outlook would be over 2 years. Once as patients learn self-management, what's the utilization pattern? So that's, obviously our study wasn't powered, or the time frame wasn't right to do that. But that's what you look at. You have to look at the longer time frames. Better management of your diabetes will reduce short-term admissions potentially, but what it's really doing is reducing your risk of complications 5 and 10 years down the road. Obviously, it's very hard to follow those types of outcomes because they become very expensive studies.
Right. Thanks. That's interesting. All right. So, are there any other questions from our group? All right. Well, I want to thank again Dr. Andrew Masica for presenting the work, and I hope those on the call found it useful and interesting. And again, we will get this information, the slides and the resources, posted on our website this week, and we'll let everybody know that. So at this point, I just wanted to move our attention toward how our HEN is doing and our current progress toward reducing readmission. So as everybody hopefully knows, and I should say here's my homage to the World Cup, is that we've, I think we're still having a lag on the data slides, but hopefully those will pull up eventually. But we have achieved our 20% reduction goal based on the new quarter of data. I'm on slide 21 for those that are able to scroll along with me. The goal is 20% reduction, and based on Q1 2014 data, we are at a 20.6% reduction from our 2011 baseline for the 30-day all-cause readmissions. So virtual congratulations and round of applause for all of our hospitals and all of you that are working on those readmissions. We hope to see this reduction at least stay there or get even lower as we continue our work throughout the year, but this is a big milestone, and the readmissions are obviously something that CMS is really, really interested in, along with the other 9 areas, but this is one area that CMS has really asked us to focus on, so we appreciate everybody's work. And again, that's my homage to, we've reached our goal as said by the soccer announcers. So here's just our charts for the 30-day Medicare readmissions, and we've achieved the goal on that too, 20.5% reduction. So again, we hope to see those rates continue to drop, but we have reached our goal as of the current quarter of data. And just finally, data tables to support those charts, but we don't need to get into those. And just a reminder for those on the call, we have based on the data you've submitted to us, provided feedback reports to the primary contacts at your hospitals or systems so you can see these data and how your rate's comparing to the overall HEN as well as hospitals of similar size to your hospital, not just for readmission, but all of the other metrics and data that you're submitting. So that's just a reminder. If you haven't seen those and are interested in seeing them, and if you don't know who the primary contact for the HEN work is at your hospitals, you can email us at admin@henlearner.org, and we'd be happy to connect you with the primary contact so you can see those feedback reports. So if there, I went through that a little bit quickly, but we just wanted to share that late-breaking data and congratulate everybody. If there are any questions on that or comments, I'll pause.
Jason, do you know is what nationally? Because I mean, I think our HEN's done some good work, but then you look across, lots of HENs are, lots of other places are seeing reduction in readmissions too. Does CMS issue like a national number, or do we know we compare to other HENs?
We haven't seen those data. I'm not exactly sure. Like I said, this is one issue that CMS is really interested in, and they're trying to kind of see how the HENs are doing across the board, essentially aggregating all the HENs, because luckily for readmissions, the metrics that everybody's tracking are fairly straightforward, and they're all tracking usually the all-cause readmissions, but that's actually the one that they'd probably be most likely to be able to aggregate and also do comparisons across the board. Some are doing specific ones. We're also tracking heart failure, but we didn't include that here. We'll be getting that information from CMS shortly because they really are focused on this. And I guess the cynic in me can't help but think that some of the reduction is related to the reimbursement changes, but I think there is definitely work done to reduce these, across the board, and we'll share those as soon as we get them. Are there any other comments or questions? Okay, so just our last point, I'm on the final slide, slide number 24. I just wanted to provide a reminder of a couple events coming up over the next month and weeks. Our next affinity call is July 11th, focused on falls and immobility. And then on July 18th, we have another special session, which we hope everybody will participate in. Will be a topic of leadership and followership, and it's basically a team-based approach to accountability for patient safety, going beyond team steps and drawing on some of the work that's gone on in other industries, like the airline industry, to have a team-based approach and accountability for patient safety. So the Chief Quality Officer here at Intermountain Healthcare, Dr. Brent James, is going to be presenting that work, and it's actually part of his advanced training program. He's beginning to include this leadership followership concept in that. So it's a new component of the training that he provides for quality improvement in healthcare. So we're really happy and honored to have him share that with our hospital engagement networks in an early stage of it. So we hope that you can join us on that. And then on August 13th, we'll have an affinity call for CLAPSI. And all that information and the information on how to connect to those events is available on our website calendar, and the link is here. So again, I want to thank Dr. Masica for presenting the work today on social determinants and readmissions. I'll do one last break for final comments or questions. Okay, well, thanks everybody for participating, and I hope you all have a great rest of your day.
Thank you.
Thank you.
Thank you.
Thanks.
Bye.